Hello, this is Peter Kistler from Heart Rhythm TV, and it's again a great pleasure to bring you a virtual cross on the back of day 2 from the Heart Rhythm Society meeting. And again, I'm very grateful to be joined by Associate Professor Neil Strathmore from the Royal Melbourne Hospital and Dr. Louise Segan, one of our PhD fellows from the Alfred Hospital. I'm going to dive right in and share my screen with you. I had a look at some of the posters, and the access to the posters now is really outstanding. And I thought I'd highlight some of these for the audience. See if I can scroll through here. This was a winner of the Eric Prostowski Prize, and it's from the Bordeaux Group, and it shows one of the great interests we have in AF ablation at the moment, and that is the vein of Marshall. And what's really interesting about this poster is it talks about the feasibility and the learning curve, together with why there may be failures to cannulate the vein of Marshall, together with some of the complications. On the back of that, the second Eric Prostowski Award was actually awarded to a non-randomized comparison study out of China, where they looked at similar lesion sets using alcohol infusion into the ligament of Marshall and compared this to the use of RF. And in this non-randomized study, there seemed to be a hint that the success might be better with alcohol infusion. The Allied Professional abstract winner was Laurel Taylor from Bill Sauer's group at the Brigham. And this is something a lot of us are thinking about, and that's same-day discharge after AF ablation. And there's some really great detail in this abstract in terms of being sensible about identifying patients who might be appropriate for same-day discharge and how to do this in a structured fashion. And then the Women in EP winner was a really elegant study from Wei Ping Song, working with Rod Tung out of the University of Chicago, and a really detailed study looking at the QRS with left bundle pacing and what to expect and some of the background to that. So the posters again were a real highlight. This was a really interesting title that I came across, and I didn't realize that we'd started to get musical with the Heart Rhythm Society. So it's an interesting, not only an interesting title, but a session worth having a look at. The last one I'll wrap up with was wearables, which again is something that patients are coming to us to discuss more and more. And this is an excellent session from Dr. Turakia out of Stanford University, who went through a range of wearables that are now available. We're all aware of the Apple Watch nowadays, and he really highlights some of the detail in what's involved in AF surveillance with the device, and particularly that it only actually looks for AF when the person's at rest. So it really doesn't provide any insights during exertion. And also that it's not just about the Apple Watch, there's also the Huawei heart study, and there's also a 450,000 retrospective Fitbit heart study that's going on. So I'd now like to turn over to Neil Strathmore for some of his pacing highlights. Thanks, Neil.
It's a great pleasure to be here. I'm actually wearing it to channel my inner Bostonian. I'm wearing an LL Bean sweater because it's cold down here in Melbourne in winter. I'm just going to share a couple of things. As I mentioned on our previous presentation for Heart Rhythm TV, there are a whole lot of interesting things going on with new technology and new techniques that we're all really interested in seeing how they're going to develop. And so, of course, one of the highlights today was, of course, the late-breaking trials, and Parekh Sharma presented the clinical outcome of left bundle branch pacing versus right ventricular pacing, which was basically looking at a non-randomized observational study comparing patients who'd had left bundle branch pacing and right ventricular pacing, and trying to match the two groups. The two groups weren't perfectly matched, but so there were some variations, and they used several endpoints. They used a combined endpoint of mortality, heart failure, hospitalization, and upgrade to biventricular pacing. And they showed that in this study, which wasn't randomized, that there were significantly fewer patients in the left bundle branch pacing group, and it seemed to be more prevalent in the group who had more pacing. So this is clearly as the two commentators, you know, in the way that it's done, there's one commentator who's meant to be pro and the other commentator is meant to be con, but in fact the commentator is supposed to be putting the study down. In fact, started out by saying that he thought it was a really great study, and although it doesn't give us the answer definitively, it certainly is both hypothesis generating, and it also tells us a lot of the features that need to go into putting together a randomized controlled study to really compare this. And it does look like the trend, as we're seeing in the posters and the abstracts and the presentations, the trend is moving rapidly towards left bundle branch pacing. And so what we're really waiting for is a definitive randomized trial comparing that to RV pacing. And I guess what we're all waiting for is maybe some new equipment that'll make it easier to do. So this is obviously going to be a key study in that area. I'm very interested in lead extraction. We've been doing this for a long time, and Rob Schaller and the group at Penn are really one of the leaders now in lead extraction. And there's a lovely paper from them about use of intracardiac echo during transvenous lead extraction, and particularly being able to look at the way the leads go through the tricuspid valve apparatus, and using the intracardiac echo to see whether you're really aggressively impinging on the tricuspid valve, because tearing of a chordae tendineae or tearing of a leaflet in the tricuspid valve is one of the bad complications of lead extraction. And so, although ICE is obviously a step up in cost, they demonstrated in their study how useful ICE was in lead extraction. And just going on from that and marrying it up to sort of a mention that I had yesterday, that one of the big questions is currently extract or abandon leads, and this was a really good summary of the issue of when you've got difficult venous access. Do you need to do an extraction of a lead to get access by putting a wire through the extraction sheath, and versus really doing venoplasty? So this is an area that's going to evolve over the next few years as people get more and more skilled with the venoplasty technique. So then a couple of other things. These were on one of the key abstracts, oral abstracts, and this was I thought a really interesting topic: the outcome of athletes with genetic heart disease and ICDs who returned to play. And basically they'd looked at a group at the Mayo, 139 athletes, 60 were female. And it was interesting that over the time of the study, 18% had a cardiac event, which was 6 per 100 patient years, and VF in 4 per 100 patient years. And these were athletes who had genetic diseases such as long QT, who had ICDs and had gone back into athletics. Interestingly, 20%, 21% had a device complication not related to sport. And unfortunately, there were no sports-related deaths in this group. So I think this is something that, again, is evolving. We've all seen the pictures of athletes having collapses on a sporting field, and just recently in the soccer, the Danish professional soccer player being rapidly resuscitated on a soccer field. And we're all faced with this issue of patients who have ICDs and who want to go back onto sport. Another abstract that was from a group with Laurie Epstein in Long Island. And I thought this was also interesting with lead extraction. One of our key issues with lead extraction is, what do you do about the patient who's pacemaker dependent? Putting in a temporary permanent lead and connecting it up to their pacemaker externally to bridge them until their blood cultures become negative. And Larry's group did a study of patients where they actually implanted a leadless pacemaker at the same time as the extraction. In fact, before they did the extraction, and had great success with no recurrence of infection. It'd be worth having a look at that abstract if you're involved in the extraction area. I'm very interested in how there's been this dramatic increase in the way we see the AV node and the His-Purkinje system that's been developed over the last few years because of His-Purkinje pacing. And there's several papers in this meeting about the anatomy of His-Purkinje, the His-Purkinje system and the AV conductance system. And I'd recommend this particular one from UCLA, but there are a number of abstracts. And if I can get this to stop rotating, I just mentioned briefly, Brian Olshansky is a great speaker in this area of vasopressor syncope, and he gives a really nice core curriculum report on whether to pace for vasopressor syncope, and the answer never or sometimes. Well, of course, the answer is sometimes, but Brian goes through the data and the guidelines and gives some practical advice with some case studies. It's a really nice study about this area. And finally, something completely different, a lovely little abstract. There's this app that's called Pacemaker ID. It's an app that you can get on your smartphone. You take a photograph of the pacemaker on an X-ray, and it comes back and tells you whether it's a Medtronic or Boston Scientific or Abbott. And on this, sorry, I'll just come back to that. And on this study, they did a series of tests with the app and looked at it, and its overall accuracy was 86%, which was certainly better than someone just eyeballing the can. And so this is an app that I've certainly got on my phone and has proved to be quite useful a lot of the time when you don't have access to exactly what pacemaker the patient actually has. So once again, a great day at Heart Rhythm, and also very interesting being able to do it from home and being able to read the abstracts, being able to watch some of the presentations both live and also on delay, and really interesting to be able to be part of it. Thanks, Peter.
Thanks very much, Neil. Over to you, Louise.
Thanks, Peter, for the opportunity. I'm very excited to be part of Heart Rhythm TV once again. And day two has certainly been packed full of content, and I can just see by the rich diversity that you've both presented how much excellent research is going on around the world. The things that caught my attention today were in the realm of lifestyle risk factor modification for AF, and there's quite a number of different presentations on this. The first one that I was really interested in was a presentation by Prof. Mikhail Reenstra, who nicely summarised the changing landscape of lifestyle-related AF risk factors, with obesity and diabetes unsurprisingly at the forefront. They've taken over the last few years. He highlighted the importance of weight reduction, physical activity, and blood pressure optimisation to reduce AF burden, citing recent seminal works from a number of countries, including Australia, where a number of excellent publications have emanated. I was really interested to see one particular study that he cited that showed patients with morbid obesity who had undergone bariatric surgery and subsequently underwent AF ablation had similar ablation outcomes when compared to non-obese individuals. And this really highlights how critical weight reduction is in the AF population and probably in other patients with cardiovascular disease. And for that reason, it's been allocated a Class 1B recommendation. But we know that in reality, this is a really challenging clinical scenario when you have a patient referred for AF ablation with morbid obesity. And we know that in reality, weight reduction is probably equally, if not more important in this situation. However, weight loss efforts have been limited due to difficulties sustaining weight loss or difficulty embarking on that journey. And we know access to bariatric services is a huge area of need in our AF population. It's an ongoing problem. So what does this hold for the future? Well, we know that lifestyle factor modification represents a real opportunity for us to make a meaningful difference in our patients with AF and their outcomes beyond pharmacotherapy and catheter ablation, and highlights the transition towards precision medicine and individualized care. And on that note, I'll just highlight one small abstract just to finish up. And this is a piece of work that caught my attention from Prash Sanders' group in South Australia, and they've published a lot of amazing work in the area of lifestyle modification. And in this particular study, they were examining the relationship between alcohol intake and incident AF risk. And we know that there is an apparent dose-dependent relationship between alcohol and AF. And in fact, alcohol abstinence has been shown to probably reduce AF recurrence, as described by Alex Bosker-Boynick and colleagues. But what our patients in the clinical scenario really want to know is what's a safe level of alcohol that they can consume. And we get asked this all the time. So this abstract confirms, unsurprisingly, that a high level of alcohol was predictably associated with incident AF. However, they had two interesting observations. The first was that they found a small amount of alcohol, less than 7 standard drinks per week, according to UK guidelines, appeared to be protective against incident AF, which is somewhat in conflict to some smaller observational studies. And the second finding that was interesting is that they found that ex-alcohol consumers had the highest risk of AF, incident AF, more so than current alcohol consumers and non-alcohol consumers. So that finding is somewhat unexpected, and that may be attributed, I wonder, to a patient population that perhaps had higher prevalence of comorbidities that predispose them to AF, but that's something possibly to tease out in future studies. So my takeaway message from this interesting abstract, which was a UK Biobank database registry study, is that although it's great to see new research and evolving research in this field, it's adding to the knowledge of the relationship between lifestyle factors and AF outcomes. We do need to exercise caution when analysing registry data, and particularly need to consider the impact of recall bias and the tendency to underreport alcohol consumption patterns in our patient population. In terms of how this might change practice, well, I think at this stage it's too early to say. And when it comes to the typical patient profile that we see in the clinic, these represent patients who are at risk or those who have established cardiovascular disease in comparison to the UK Biobank, which is predominantly healthy individuals. And so the old adage of less is more is probably still relevant today until we have more compelling evidence to the contrary. Thanks, Peter. I'll hand back to you.
Thanks very much, Louise, and thank you, Neil. And again, we really appreciate the ability to deliver a virtual wrap up for day 2, and look forward to hopefully seeing everyone next year in person. Thanks again.